All right. Hi, and welcome everyone to comprehensive biomarker testing in non-small cell lung cancer. So today we want to cover the why is this important? Why find out more information about each person's disease? Why does it matter? And we have two incredible experts joining us today to talk about that. Here at The Patient Story, we're a multi-channel platform that I started when I was going through my own cancer diagnosis. At the time, I felt very alone, and I wanted to understand in human terms, not medical jargon, how to navigate life after diagnosis. And so we specialize in in-depth patient stories and informative discussions like today's, with a goal to connect you to each other and to information that's useful when and where you need it. Now, before we get to our conversation, we want to take the time to thank our sponsors for today's program, AbbVie and Nuvation Bio, for their support of our educational content, which allows us to build more of this programming for patients and care partners out there. Now, it's important to note that the Patient Story retains full editorial control of the content. And also, this is not medical advice, so it should not take the place of your own healthcare team conversations. But we do hope you walk away with better information and questions to ask. Finally, we really want to know what you think, so we can host more programs and content in the ways and focusing on the topics that you want. So a survey will pop up at the end of this conversation and should just take a couple minutes to fill out. With all of that aside, I'm so excited to introduce our two experts today. Jill Feldman, who became a lung cancer patient advocate after she lost her grandparents, her aunt, her own parents to lung cancer. And then she was diagnosed herself with lung cancer in 2009. She co-founded the EGFR Resisters, a global patient-driven grassroots advocacy group dedicated to supporting people with EGFR positive lung cancer. And she serves on multiple advocacy and advisory boards. She's told her story many times here at The Patient Story. And honestly, I am so in awe of Jill. Also, I'm a big fan of Dr. Eric Singhi, a medical oncologist at the MD Anderson Cancer Center in Texas. He specializes in lung cancer, focused on biomarker-driven treatment strategies, inclusive of targeted therapies, has become a very well-known clinical researcher and patient advocate who, by the way, has also built a social media following of his own. So Dr. Singhi and Jill, I really want to thank you so much for joining us today. And Jill, I'll send it over to you.
Thank you, Stephanie. Hi, everyone. My name is Jill Feldman, and I'm a lung cancer patient and longtime advocate. And I know firsthand that when you hear the words, you have lung cancer, your world begins to spin. Everything becomes urgent. You want answers, you want a plan, and you want it now. And then you're told, well, we need to wait at least 2 weeks for biomarker testing. And you think, wait, really? Because, that is the last thing you want to do. So today we're going to talk about why that wait matters and how biomarker testing helps make sure that you get the right treatment, not the fastest one. Because this is not only about finding the right treatment, it is also about avoiding the wrong treatment. And I am thrilled to be joined today by my friend, the amazing Dr. Eric Singhi from MD Anderson. So let's get started.
Thanks, Jill. Excited to be here and excited to always reunite and unpack conversations with you.
Me too. You are really great at educating patients, and I'm so thrilled that you could join us. So let's start at the beginning. When people hear biomarker testing, a lot of times it's what's said actually is mutation or genetic testing. So patients often think, oh my gosh, genetics, ancestry, or something that they pass down to their children. But that's not what this is at all. So can you explain what we are actually talking about when we say biomarker testing?
Yeah, so this is a really important question. It's a great question. Honestly, probably one of the most important questions in lung cancer care today. So at its core, biomarker testing is trying to understand what is driving your particular cancer. So when I meet patients and their families for the first time, they're diagnosed with lung cancer, I tell them, hey, I don't just want to treat lung cancer, I want to treat your lung cancer. And that's really important. And it's honestly a privilege being a medical oncologist focused in lung cancer, because now we have the opportunity to really try and personalize our treatments for patients, really personalize the biology, go against what's driving the lung cancer to grow. And so if you think about it, every cancer really has a reason it's growing. And we're trying to find that reason. And in lung cancer, we call that a driver mutation. And so there's a lot of different analogies. One may be the lock and key analogy. So I'll give you that one. So if your cancer is a lock, right, the biomarker is the shape of that lock. And the treatment is going to be the key that opens it, that really controls it. And if we don't know the shape of the lock, we might use the wrong key, right? And that means that the treatment may not work, or even worse, it could be unnecessary, it could cause toxicity, and then patients get into trouble without getting any benefit. And so that's overarching what biomarker testing means and why we do it.
I love that lock and key analogy because it's very visual and it's very universal and everyone can understand it. And I want to emphasize again that most of what we are talking about today are changes in the cancer itself, not something that you were born with, you inherited, or you could pass down to your children.
So really, when we're talking about genetic testing in lung cancer, we're only looking at genetic changes, biomarker changes in the tumor cells themselves. So all the testing that we do inherently sort of upfront for lung cancer testing is only on those tumor cells. We're not really looking at other changes, genetic changes, in all the other cells in your body. And those are the ones that may come or be inherited from parents, right? So really, we're looking at genetic changes of the tumors, not really genetic changes of yourself. And so that's a really important point to emphasize. Yeah.
Okay, so let's talk about timing because this is where patients feel the most stress, right? You've been told you have lung cancer, you're scared, maybe you're having symptoms, and then you're told, well, we need to wait for these biomarker results. And to be quite honest, for a lot of people in patients in general, in your mind, all you can think is, oh my gosh, is my cancer growing bigger and bigger every day? Why am I waiting? The weight is heavy and it can feel unbearable. I still feel it every single time I'm waiting for biomarker results. But it's important. And Eric, can you talk about why it's so important to get the biomarker testing results before starting treatment?
When I meet patients and their families, they're newly diagnosed with cancer. Usually it's another physician that tells them, hey, you have cancer. Now you got to go see an oncologist. And by that point, they're usually waiting 1 week, maybe even longer to get in to come see me. They've already started thinking about questions. They're anxious to get started. And so I absolutely want to acknowledge and validate that feeling of feeling the anxiety, wanting to get started. But Jill, you're right. It's really important, particularly for non-small cell lung cancer, to get those biomarker testing results before we start treatment. That's in the ideal world. I do want to say that there are some cases where if patients are symptomatic, if they're having a lot of trouble breathing, if really the cancer is growing quickly and causing symptoms that are causing trouble, there are unique circumstances where we have to start treatment. And if we start treatment, we will typically start with chemotherapy by itself, right? While we're waiting for the biomarker testing to come back. And so, yes, there are those exceptions. And I'll talk to patients and I'll say, hey, these are some red flags we need to watch for while we're waiting for biomarker testing. If A, B, or C happens, call me. But you also need to go into your local emergency center, and we may need to pivot into giving chemotherapy sooner rather than later. That being said, we've actually looked back to see how patients do if they have their biomarker testing results before they start treatment, or if they don't and we start a treatment. And looking back, we have real world studies. We have evidence now that tells us that patients that waited to get their biomarker testing results before they started their treatment, they actually lived longer. They did better. And so we have data to say, yes, the wait is worth it because it really impacts your clinical outcomes. It gives you the opportunity to get more benefit out of the treatment that we choose and hopefully have less toxicity.
And so when it comes to testing, we have two main ways to test, right? We have a tissue biopsy and we have a liquid biopsy. And they both have their strengths and their limitations.
Yeah. So I think one of the points to emphasize, we throw this buzzword around called comprehensive biomarker testing. And I think we as a community are still trying to define it. And the way I describe it is that comprehensive biomarker testing is not just one test, it's actually a strategy. Really, sometimes biomarker testing is not just one sample. It can be a tissue, but it can also be a liquid. And so tissue biopsy is our gold standard. That's where we have to go and get tissue of the tumor, either from the primary lung location or if it's moved to another site. That's what our gold standard is. We'll get the tissue, we'll run some tests in the lab, and then we'll get those results back in about 2 to 3 weeks. But then there's also an opportunity for more non-invasive tests, which we call a liquid biopsy. And that's a blood test, usually 2 vials. And that can typically give us answers faster, sometimes even give us a broader snapshot of what's going on. What's really important to emphasize is that these tests are complementary. They are not competing, they are complementary. What I mean by that is if a liquid biopsy comes back negative, it does not rule anything out. So you need to use both so you don't miss anything important. At the same time, if something comes back positive, we go with it. But if it's negative, you can't always go with it. You have to wait for that tissue biopsy. So that's a little bit about tissue versus liquid.
When people aren't explained exactly why they have to have one or the other or have both, you don't really understand what's going on. So it's okay to talk to your doctor and ask questions and ask, did anything come back on the liquid biopsy? Should I have a tissue biopsy? Are there are times you may not be able to get enough tissue. So asking those questions it's really, really important. I just want to point out one thing is that a lot of times comprehensive biomarker testing is referred to, people use the term NGS.
Yeah.
And that means next generation sequencing. If you hear what's important, if you hear NGS, they are talking about comprehensive biomarker testing. Eric, can you talk about the different testing a little bit?
So, what the comprehensive component means in comprehensive biomarker testing is we're not just checking 1 or 2 genes. What we're doing is broad panel testing. We're looking across many possible biomarkers all at once. And we do that through looking at different DNA tests, but also RNA tests. And so there's a lot of nuances to this, but really the emphasis is you don't want to be looking at 1 or 2 genes. You want to be looking at many genes at one time. And that's really a big emphasis of comprehensive testing.
Okay, so now we've talked about how we test, when we test. Let's look into what we're actually looking for and maybe some of the most common biomarkers and why they matter. And can we start with the ones that we've known for the longest, which are EGFR and ALK?
I know EGFR is very near and dear to you, Jill, especially with your EGFR Resisters organization. You're right. We discovered EGFR mutations in lung cancer in 2004. So we only recently celebrated 20 years of understanding that mutation of lung cancer, what it meant for patients, what it meant for their treatment and their outcomes, right? And so you're absolutely right. EGFR is really important. I'll start with that one. What I want to say from the start is that not all EGFR mutations are the same. And so that's really important. EGFR, if you just throw that out there, that's like giving the zip code. What I tell people is you need to know more than just the zip code. You want to know the home address. And so what that means is there are very common EGFR mutations. The 2 most common ones are called exon 19 deletion and L858R, and they make up the majority of EGFR positive lung cancer. The good news is with these mutations, they tend to respond quite well to many of our standard therapies, whether by itself or in combination with other drugs. But then there's also less common mutations with EGFR. So some less ones that I'll throw out there: exon 20 insertions, G719X, S768I, a lot of letters there and numbers. But the emphasis with this is understanding that these are less common and they can behave differently. And as a result, your treatment team may pool different treatments or talk to you about different treatments that may be more effective in that circumstance, maybe even have a different tolerability.
Yeah. Definitely. And that's why it's important to get that comprehensive testing. And so, something else, can you talk about also, when we talk about targeted therapies, how are they different than what people, think initially as old school chemotherapy? And before you explain that, I just want to emphasize there is a role for chemotherapy, especially in EGFR cancer. It does work. It may not be the right first treatment always, but it does work and there is a role for it. But could you explain the difference?
So there's different buckets of treatments. So chemotherapy is what people traditionally think of when you hear cancer and you think about treatments. What that does is it's a drug typically given through the vein, sometimes orally, but usually through the vein. And what it does is it's honestly non-selectively killing very fast-growing cells. So definitely the cancer cells, but also some other normal cells, like cells that are growing fast, such as your hair, which is why you can have hair loss, cells that line your gut, which is why you can have nausea or diarrhea. So that's chemotherapy. Targeted therapy, the way it works is by going after a very specific weakness in the cancer. And this goes back to the biomarker testing. We want to identify what that weakness is. We want to identify what that signal is that's causing the cancer to grow. And so this is very precisely going after that signal that's causing the cancer to grow, and it's shutting it down. And so the good news is it's very precise. Usually the response rates can be very high. And hopefully, because it's going very directly after those cancer cells, side effect profile is less than chemotherapy and typically better tolerated than chemotherapy. So that's the big difference between targeted therapy and chemo.
So, a KRAS used to be the undruggable target, right? So actually, KRAS has been around much longer than EGFR. But KRAS is common, but there are also some other not so common biomarkers such as ROS1 and BRAF and RET and NTRK. Can you talk about those a little bit?
I think what you're highlighting, Jill, is really important, that not all of the cancer changes are the same. And two common types that we look for are mutations or fusions. So mutations happen within a change in a single gene. And then there's something called a fusion, which are less common, but still really important. And the way I think about fusions is two different genes get stuck together. Both a mutation, both a fusion can cause cancers to grow. They drive the cancer growth, but they're found in different ways. They're treated in different ways. They're found, in different frequencies as well in the population. And so you mentioned KRAS. KRAS makes up almost about a quarter of patients' mutations if they have a mutation in non-squamous non-small cell lung cancer. So it's a pretty big chunk, right? Almost about 25%. One specific KRAS submutation is called KRAS G12C, C as in cat. And so that last letter is really important because that tells you about the exact subtype of KRAS mutation that the patient may have that's driving their disease. Currently, what we have approved are drugs specific to that KRAS G12C mutation. But there are a lot of exciting clinical trials trying to go after even other KRAS mutations. And we're seeing promise, we're seeing hope. And so we're continuing to really focus on targets and find drugs to match to those targets.
Yeah, that is really exciting. And it just shows you that science wasn't wrong at the time. It was undruggable, but now as science evolves,
Yeah.
you learn more. And I think that is important to keep in mind. It's not always so concrete. And then and again, I think it really emphasizes the importance of biomarker testing. And when you get to ROS1 and RET and BRAF and NTRK, they're rare, very rare. You could talk about just a few percent of the population. But why are they important to find as well?
Yeah, so several of the ones that you mentioned are fusion. So like the ROS1 fusion, for example, you're right. It's not very common, but it's still very, very meaningful, critically important to find because when we do find them, we actually have targeted therapies that are approved, even further targeted therapies that are being studied in clinical trials that are highly effective, that are very precise. And so if you find this clue that's driving that cancer cell to grow, we can find a drug that works very effectively, not only against the primary tumor that's in the lung, but many of these tumors will also go to the brain, even at time of diagnosis when we're initially staging a patient, we find disease in the brain. And these drugs can actually work really well and go against the blood-brain barrier, right? They can actually have an impact on disease in the brain. And so can work well, can be very precise, and can work in different areas.
I think that's something very important to emphasize as well. Waiting for biomarker testing before treatment also means before radiation treatment in the brain. Of course, there are circumstances where you have to, but these drugs work so well in the brain. I've known people who have had dozens and go on the drug and they all go away. And so again, this is another reason it's really, really important to wait for those testing results. So let's shift a little. So we talked about the targeted therapy. Now we're going to talk about protein markers, which is a different kind of biomarker. They aren't, and why they're important. I'll let the expert explain it because he can do a much better job than I.
I'm learning a lot from you, Jill. So I love learning from my patients because it allows me to take our conversations back and really translate it into a way that they can understand. And they say, okay, I got it. Now I understand. And you become a true partner in your care. So I'm learning a ton from you. What I will add on to what you're saying is biomarkers, this definition of biomarkers continues to evolve, right? And so we talked a lot about NGS, next generation sequencing, looking at the DNA, the RNA. That's looking at the cancer's blueprint. That's how I explain it. What you're talking about is looking for proteins that the cancer may be expressing. And we do that through a different testing method, which we call IHC, immunohistochemistry. I feel like we need subtitles for all of these different abbreviations that we're throwing out, right? But what I will just try to say for patients listening to this, there's multiple ways to check for biomarkers. And when we get into the weeds, you can look at proteins, but you can also look at the cancer's blueprint, and that's looking at the genes. And so the proteins are now becoming very important to understand for the treatment of lung cancer.
Yeah. And, I think as you talk about these different tests, I want to emphasize that, the protein testing is not a substitute for the comprehensive biomarker testing. It's a piece of the puzzle, not the whole picture.
Yeah.
And so what do the results from the protein testing, what do they mean?
Yeah. So I'll give you an example of one that we've been using for some time now that helps us think about what treatment we're going to use for a patient with non-small cell lung cancer. And that's called PD-L1. So PD-L1, this is not a mutation, it's a protein. And what this protein does is it helps cancer hide from the immune system. And so when we're thinking about, can we use a drug like immunotherapy? We haven't even talked about this class of drugs yet. This protein, depending on how much is expressed on the cancer cells, can help guide our treatment decision making. Is immunotherapy going to work by itself really well? Is immunotherapy going to not work very well by itself? Do we need to add another partner to it like chemotherapy? It's helping us think about treatment decision making. Immunotherapy, the way that I describe how that works is usually your cancer cells do a really good job of wearing a cloak, and it can hide from the soldiers of your immune system, which we call the T cells. The job of immunotherapy is to really rip off the cloak that is hiding the cancer cells from your T cells, from your immune system. And once we rip off that cloak, now your immune system, the T cells, can finally recognize that, hey, there's something foreign here, foreign being cancer, something that's not supposed to be in my body, something that's not healthy. Now I can use my own immune system to really activate and go after the cancer cells. And so that's what immunotherapy, that's why it's so important in non-small cell lung cancer. And that's why it's a huge advancement for many patients.
So basically, you're not targeting the cancer like you are with the other treatments. You are just helping the immune system get back to what it's supposed to be doing.
Cancer is very smart. And so really what we're doing is exposing the cancer cells finally to our immune system to say, hey, listen, this does not need to be here. And we need to train our own body to go after the cancer cells.
I've heard stories, and you've probably experienced it, where people come into your office and ask for immunotherapy. And it's really, really, they don't understand that there are all these different types of treatment and not all lung cancer is the same. So I think that's one thing to emphasize. And the other is not every biomarker has an approved immunotherapy in every setting.
Right.
But it's still really important and still matters to get all the testing done for treatment planning, for clinical trials, and for understanding what may or may not be the next step.
I think that's a really important point, Jill. So I really like how you keep talking about the pieces of the puzzle. And so PD-L1 is an important test, but again, it's only one piece of the puzzle. And that one piece, you're right, can come back very quickly, often quicker than those results of NGS or some of the DNA testing or RNA testing. What PD-L1 does is it tells us how likely immunotherapy is to work, but it does not tell us what is driving the cancer. That's what biomarker testing NGS tells us, right? And so you have to wait for all those different pieces of the puzzle to come back because you need to put it all together. Because initially you might be fooled with a PD-L1. If it's really high, oh, immunotherapy might work. But then you eventually get back your full results and you find that you have an EGFR mutation, right? A common one. Those actually don't work very well with immunotherapy. And so that's why it's really important to have all those pieces before you make your decision.
Mm-hmm. And because you're talking about EGFR and immunotherapy, I want to stress that if you are waiting for your biomarker results and you do have symptoms, you don't want to start with immunotherapy. It can be dangerous to, have immunotherapy and then start an EGFR targeted therapy. We do have data on that. And I think, as you said earlier, Eric, chemotherapy is usually the best place to start.
Absolutely.
So want to repeat that. That's important. Okay. So we've covered the most common biomarkers. Let's talk about one that it causes a lot of confusion, and that is MET. MET can show up different ways, and understanding that is really important because you test for it differently, and it really has two different ways that it behaves. So, it's still a bit confusing to me. So, Eric, can you help us break down the difference between MET exon 14 skipping and c-MET overexpression?
You're absolutely right. It's MET, M-E-T is really important in lung cancer. And I'll be honest, it's one of the more complex biomarkers. So I'm going to try to simplify it. There's really three ways, actually, that we think about how MET can show up in lung cancer. Yeah. So one is the mutation, which you talked about. So MET exon 14 skipping mutation. It's a very long name. But this is what we call the classic driver mutation, meaning that's what's directly fueling the cancer. And you can treat that with targeted drugs, targeted pills, which we already have approved. And so that's the first one. The second one is actually a gene copy increase. And so what does that mean? We call it MET amplification. And so if you think about it, I think the easy way to explain it is the cancer is turning up the volume on MET signaling. And so you test that in a very different way. You don't actually do that typically just with NGS. You can also do it with another form of testing. And this one is important because oftentimes for patients who have EGFR disease, if they're on a targeted therapy and that targeted therapy stops working, we want to understand why. Why is it not working? And we call that a resistance mechanism. And MET amplification, where you turn up the volume of the MET signaling, can be the reason why. So you want to check for that as well, right? And then the third one that you mentioned is all about protein level expression. And we call that MET, c-MET overexpression. And so sometimes you can have too much of this MET protein on the cancer cell surface. And you do that with protein testing, which we call IHC. And this one is not about the gene. It's actually about what the cell is expressing itself. And so those are three different ways of checking for MET. And they all necessarily don't mean the same thing. If you have one that's positive, the other one may not be positive. And so it's very complex. So when you talk to your team, say, hey, have I been tested for MET? And if so, how? Because I think it's really important to understand that.
So they're not mutually exclusive?
They're not always concordant in terms of the results. You may have one that's negative, but if you check another way, that one could be positive. And so that's why you want to understand, really for MET, I would say the devil is truly in the details. You want to understand, was I tested? And if so, how?
Okay. And so outside of the MET exon 14 skipping, how do you treat the other two?
Yeah, so it's a really good question. With MET amplification, that can emerge as a resistance mechanism for many patients that are on EGFR targeted therapy and oral therapy, even sometimes even a quarter of patients, if they're on an oral targeted therapy, 25% of the time you can see this. So if you find a resistance mechanism. So pretty common. What do you do in those circumstances? One, there are clinical trials looking at this, but there's also clinical trial data that is read out where you can not only continue the EGFR targeted drug, but add in another drug that goes against the MET pathway. So a combination strategy to go after it. There's a lot of nuances to this. You should talk to your team. But there are some ways, there are data to overcome that resistance mechanism. For the protein overexpression, the c-MET protein overexpression, we have a very recent approval of an antibody drug conjugate. This is now the fourth class of drugs that we're talking about in just this story that we're talking about, right? So antibody drug conjugates, I call it sexy chemo or targeted chemo. We'll kind of go into what that means. But there is a drug now for patients if they have a high level of protein expression, c-MET protein overexpression, an antibody drug conjugate is approved for patients.
It wasn't that long ago that there was chemotherapy only. So
Yes.
the field is rapidly moving and it's hard to keep up with. Something every patient worries about, which is progression, because that is when the cancer changes or it starts to grow again. And while we dread it, it is something that we really should understand enough to know that the cancer can do that, and that sometimes you could have progression where the treatment isn't really helping the cancer at all, or sometimes you could have progression in one little area where the treatment is still working everywhere else. It's an important question to ask your team if you are told that you've had progression.
Yeah. Probably one of the toughest conversations to have in clinic, right? So unfortunately, cancer is not static. It often evolves, and it's something that we typically see over time, unfortunately start to expect. And you're right. When this happens, we want to understand how is it happening? How quickly is it happening? Where is it happening? So when I'm thinking about progression, I'm thinking about the time. So how soon after starting a drug is the patient having sites of disease that's growing, is no longer responding to the drug, and then thinking about how many sites, right? So what you're talking about is what we call polymetastatic disease, polymetastatic progression, where multiple sites are growing all at once despite being on a drug. If that happens, oftentimes we're needing to switch our drug. We're needing to think about a new treatment option. But you want to understand, why is that happening? That's what's really important. So we talked about biomarker testing in the beginning. Don't start any treatment until you get those biomarker testing results. Well, what's also an important takeaway from our conversation is that you have to test again. And you should figure out why. Try to understand, why is the cancer growing? What changed? Did the actual cancer cells themselves change? Sometimes that can happen, not commonly, but it can, where you can go from a non-small cell lung cancer to a small cell lung cancer, a much more aggressive, fast-growing type of lung cancer. Or have we developed different mechanisms of resistance? There's two categories of resistance that I think about generally. One is called on target, where let's say you have an EGFR mutation in the beginning, you're started on a targeted therapy, it's doing really well, and then unfortunately the disease starts to grow, you repeat your testing, and now you find what we call an on-target mechanism of resistance. What that means is the original mutation has changed shape. And so it's still going down the EGFR pathway, but the original mutation has changed shape. Then there's an off-target potential of a mechanism of resistance, and that's what I call like a bypass mechanism, where the cancer just finds a new route, it finds a new pathway, and one that we already talked about was MET amplification. And so you want to understand why, because it has implications for thinking about that next treatment, thinking about even combination treatments, thinking about clinical trials. And so, yes, I think the key takeaway again is understanding, why is the cancer growing?
Yeah, and I guess I know you don't have the end all be all answer, but a lot of people do ask, why is resistance happening? Why does it happen?
Yeah, I think it's a really good question. There's two sort of patterns of resistance. You can have a primary resistance where you start a patient on the drug and the drug just doesn't work from the get-go. And then you have an acquired resistance where over time, then the cancer drug starts to work less effectively. That's more common. And the reason why that happens is because you can maybe get to a threshold of control of the cancer cells with the drug that you're using, but it leaves behind some of these persistent cells, these cells that just stay there and they start to cause problems. They start to get smart, they start to evolve, and then they start to build. And they build up to the size of a tumor. And then that tumor becomes visible in scans. And that's where you start to visualize and see, hey, maybe this drug isn't working. And so that's the more common scenario. And that's sort of a general reason of why that happens.
It is really important to get that testing once again so that you can make your plan for the next line of treatment. Again, you want to know what is driving that resistance. I just want to point out what you said about on target mutation changing shape. I want to go back to your key and lock analogy. So it's kind of like you get a new lock, right? Because of some reason, and your key no longer fits in that lock.
Yes.
And so is that okay? Is that a good way to
Absolutely right.
explain it?
Yes. We're going back to the key and lock analogy. Exactly right.
Okay, so I really, it helps to visualize it. It helps you understand it. So then there's progression where you may have only progression in one spot, but the main cancer, and if it was anywhere else, all of that is still stable. So the treatment is still working on those areas. Should you change treatments, or are there other options?
Yeah, this is a really good question. So we talked about many sites growing on your treatment. Now we're talking about just a few sites, maybe 1 up to 3 sites growing. The rest of the disease remains well controlled on the drug that you're on. In these circumstances, if you have a drug that's working well, that's overall controlling the disease burden, if the patient is feeling well, and importantly, if they're tolerating that drug well, right? They have to be having a good experience overall in terms of quality of life, being able to manage side effects that come with that drug. If all of that is in their favor, then we do talk about using what we call local therapies to try and control some of these bad acting cells that are growing, some of these bad acting tumors that are starting to pop up. And what do I mean by local therapy? I mean, radiation is an option where you can call in a friendly radiation oncologist to say, hey, listen, I have a spot, let's say 1 spot in the brain or 1 spot in the bone. Can we radiate it? Can we zap it, take care of it, and continue the drug that for the most part is working really well? And that's a very reasonable option. Many of us have had patients where we've done that. We've been able to continue the same drug for many months, even years. So that's a really good opportunity to think about that.
Yeah, it is. And I've had a lot of that radiation, and it probably 7 different nodules. And, it's allowed me to stay on the treatment I'm on. But, the radiation that you're talking about is also very targeted
Yes.
radiation. So I just want to emphasize it's not old school where you go every day for 6 weeks and it's 5 minutes, but it is targeted radiation. It preserves healthy lung tissue. And so, again, I think, 2 things here really to emphasize is that this is why you want to ask your team what type of progression you have so
Yes.
that you can advocate for yourself depending on whether it's one spot or whether multiple areas have grown. And the other is this is where comprehensive biomarker retesting is really important. And the question I want to ask you is
Mhm.
what is the role when we were talking about tissue biopsy versus liquid biopsy when you're first diagnosed.
Mhm.
So upon progression, is this where liquid biopsy can be like a powerful first step? Do you use it first?
Yeah, so this is really important. So what I would say is liquid first strategy is pretty common. So we will often start with a liquid biopsy because it's fast, it's minimally invasive, it can capture the whole body and what's going on. But a really important rule is that if that liquid biopsy is negative, you should follow with a tissue testing ideally, because that's the only way right now where we can understand if the actual cells have changed, if you've had transformation of non-small cell lung cancer to small cell lung cancer, and truly be comprehensive in figuring out if there's a new biomarker that's driving this progression.
That's critical. Yeah, that's really critical. So the goal is find out what's driving the cancer now.
Mhm.
And so I think when progression happens, I also encourage people to ask your team, can we start with a liquid biopsy and talk about if it doesn't provide information, should we consider a tissue biopsy? And ask, what are you testing for, to understand why the cancer is growing? It is, when you ask your team these questions, it's not, you're not being confrontational. You are the CEO of your health, and you want to know everything's being done, what the next steps are, so that you can understand it better, because knowledge is power.
Yeah. And what I'll say too is just three questions. What type of progression? Why the progression? And how are we going to deal with it? What, why, how?
And so I think one of the things is it's not a trade-off, quality of life for treatment. You should be able to live longer and live well. And so, we talked about earlier that some of the therapies have more acute side effects, some of them have less side effects, but you're on the drug longer, so they can be more persistent. And so there, I think it's important to understand that low grade does not mean low impact. Any side effect can impact anybody, and it's different ways. We respond different ways, but if it impacts your daily life, you absolutely should talk to your team about it. But, one thing I want to point out too, which, a lot of us, a lot of patients with the newer therapies, the treatment decisions aren't just about how long something works. They're about what your life looks like on that treatment. And for many people, the targeted therapies, they're a pill,
Yeah.
and you go every 3 months, right? So there is a real psychological relief first in knowing that you could take a little bit of a break and you don't have to go in every few weeks for treatment. But there's also a psychological relief knowing that there is like a tailored plan for
Mm.
your cancer. And so do you see that a lot with your patients?
Yeah, absolutely. I think when we talk about the toxicity, you're absolutely right. We are always so focused on the side effects that we can see, right? The skin changes, the rash, you name it. But there's also that component of time toxicity. And I think you highlighted it and said it so nicely, right? We really need to weigh that in. How often can patients come to the cancer center? How often do they want to come? How often do they have other obligations where they need to live their life outside the cancer center? That's the whole reason why we do what we do, right? To allow patients to live a life that has meaning, that has quality, while also taking care of their cancer. And so you're absolutely right. I think the psychological aspect, the mind, body, soul connection in the cancer care journey is so important. My patients hear it all the time. That's all I talk about with them. And I talk about it with everyone, to be honest.
And the other thing I would emphasize in talking about quality of life is it's different for everybody, right? If you're young and you have young children, like I was when I was diagnosed, I was worried about one thing, raising my children. And as if you're older and you're retired, you may worry about certain side effects more. If, like neuropathy, if you play the violin or the piano or you garden, and it just depends. So your preferences, your goals, your family, and how it will impact your family, those are all important pieces of that conversation to get the whole picture. When it comes to comprehensive biomarker testing. If you're asking your doctor for it and your doctor says, well, I don't think we need to test for that. Um, you know, do you think it's okay to ask why?
Absolutely. Yes. I would understand why. And I would understand, make sure we get into the details, right? We keep talking about the devil's in the details. Okay, biomarker testing, sure. Maybe we don't understand and we're talking about just the repeating the DNA, repeating the RNA, but what about the proteins? So ask about those details, ask why and why not, I think is another question to ask.
Is there ever a good reason why not?
Sometimes there are. So sometimes if there's not enough tissue, right? If we don't have enough tissue sample to run the test, sometimes we don't expect changes necessarily happening in the tumor evolution to go looking after it. So there are sometimes reasons, but I think any oncology team should be able to explain those reasons why. What I'll emphasize is that we're very privileged in our lung cancer treatments today because we have options and we're being able to personalize options for patients. But we do that with biomarker testing, right? And so if your oncology team can't exactly explain why we don't need biomarker testing, then I would go and seek out a second opinion. I would go talk to another center and really make sure we're all on the same page.
Yeah, that's a great point. A second opinion is important, especially if it's going to help you feel better that, everyone's on the same page. And, it's important for a lot of people, but also you have to keep in mind it's not about mistrust.
Right. Right.
That's not, and if the person you're with, if the oncologist you're with if that's how they feel, then you really need to think about the situation you're in, the team you're seeing, and whether you'll be comfortable talking to them about everything that you need to talk to them about across this experience. But it really is, I think, a way to make sure all options have been considered. You're not being difficult, you're being informed. And I'll just add that, when I have progression, my oncologist is like, okay, I'll talk to these people, you talk to these people. And so, that's what you want, is someone who is open to that.
Yeah.
So it's important. Okay, so one thing I really want to emphasize is treating lung cancer is more complex and complicated than ever before, but no one has to navigate this alone. There are groups like the EGFR resistors that exist because patients need a community that can provide information and support. And there are many groups for different biomarkers, different diagnoses, and specific treatments. And I have to say, in some ways and sometimes they are life saving, but they are almost always life changing for patients and caregivers, because these communities help people understand their options, connect with others who truly get it, and feel less alone when everything else feels completely overwhelming. And so to have a place to, be able to get education and support and also empower you, because most of these groups share important questions and best practices. It all helps you make more informed decisions and know you are not alone. So, with all that in mind, the science, the testing, the advocacy, and the community, let's wrap it up with some closing thoughts. So, Eric, I'm going to ask you the same question that I like to ask experts, and that is, what is the one thing or the three things you want people to remember from today?
Yeah. Well, first of all, thank you for having me, Jill. I love always chatting with you, and I learn so much every time I talk to you. So thank you for that. What I would say in terms of key takeaways, biomarker testing is incredibly important in lung cancer. We are not just trying to treat lung cancer, we're truly trying to treat your lung cancer. And I really emphasize your in that sentence, because it's incredible the advancements that we've made for patients with lung cancer. We have a long way to go, but we've definitely made strides. And I think having access to those improvements, those advancements is so important. And that's through clinical trials, through research, through science. And that's also through the guidance of biomarker testing. So that's a really big takeaway. And the second takeaway I would say is, We've also talked about this buzzword about empowerment, being an empowered patient. And sometimes that can be overwhelming when you think about that term. And so what I tell patients is being an empowered patient doesn't mean you have to know everything, but what it does mean is that you should feel included, heard, and supported in your care. And I think support and communities can help do that. And it's really important to feel like you're really heard and included by your team.
That's a really good point and such an important message. And I think you're right. You don't have to know everything. And it's okay to even tell your doctor, I want you to make the decision. I mean, I know people who have done that, but that's being heard, being included. I mean, it is so important. So thank you for pointing that out. And, if there's one practical takeaway or a couple practical takeaways or bullet points, I would say it's test early, test broadly, ask for your report so you could have discussions with your doctor and really find a community where you can connect with others who get it in a way that no one else can who hasn't lived it. And, I'm stressing again, you don't have to know everything. You just need to know that there is information out there. There are communities out there. There are people out there who will help you navigate this roller coaster ride. I like to call it sometimes because that's what it feels like in the beginning. But thank you all for being here. And Eric, thank you. I absolutely love working with you. Just a little bit of information to everyone. I've known Eric since he was a fellow.
Yes.
And it's amazing. He's a rising star, and it warms my heart to see that his true north is still, making sure that patients understand and that they're heard. That really is special. So thank you. And, thank you to the patient story. And I will send it back to you, Stephanie.
Thank you so much, Jill. And thank you, Dr. Singhi. I really appreciate the both of you joining in spite of your very packed schedule, but also just leading a conversation, not only with so much information, but presented in a way that I think is so digestible for all of us out here. And some of the key takeaways for me include that comprehensive biomarker testing can be a real big tool in major treatment decision making. And that's at diagnosis. And also, again, if the cancer changes. And also that it's more than okay, but really important to advocate for yourself. And this is something I learned as a patient and in the many years now that I've been a patient advocate also. But in this situation, some specifics I've learned are, hey, maybe ask if you've had both tissue and liquid biopsies done. Ask for a copy of the biomarker report. Ask your healthcare team to explain what was tested, what it means, why a treatment is being recommended now, and so many other things, so that you walk away from every conversation with your own doctor, understanding so much more. Now, on that note, again, this conversation is not a substitute for the medical advice and conversation with your own healthcare team. Consult with them as you're making treatment decisions. We do hope that you walk away with better questions to ask. So we also want to thank again our sponsors, AbbVie and Nuvation Bio, for their support of our educational programming, which the patient story retains full editorial control over. And for important shout outs here, Jill mentioned, Dr. Singhi mentioned during the conversation, but there are so many incredible lung cancer patient advocacy groups out there. Again, Jill leads the EGFR Resisters. They have so many different, resources and programs and educational information for people out there. And there are also many others. We'll send more details in a follow-up email, but some are the Ross Wonders, KRAS Kickers, ALK Positive, the White Ribbon Project. And they all have resources that are biomarker specific and also for patients and care partners dealing with lung cancer in general. And remember, your voice and opinions really matter to us as we're building more content for you. So this feedback survey should just take a couple of minutes. It's going to come on screen right when I stop talking. And I really hope that we hear from you and that we get to see you again soon. For now, I'm Stephanie Trong with The Patient's Story. Take good care.